asking me to talk to you guys. I don't usually get the opportunity to speak to this type of crowd, and you know, non-medical group. So actually, it's very nice and it's very refreshing to tell you the truth. Because I speak to medical students a lot. I speak to physicians a lot, and so forth. So I'm an infectious disease specialist. I've been working at HSN, the hospital here, for a long time, for about 24 years or so. I deal with the whole field of infectious diseases, of which Blastomycosis is one. So I'm gonna go through slides. I'm not gonna go through all of these. I'll try to. I'm gonna skip some of them because they're not of relevance to you. But there's some interest in Blastomycosis, some occupational risks with it. So I'm gonna go through a couple of cases because Caleb said that'd be kind of interesting to see some cases that I've seen and how they presented. Hopefully it's not full of too much medical jargon and lingo, and if it is, just ask me. I don't want to talk in a lot of unnecessary jargon. I'm going to talk a little bit about the biology of Blastomyces, which is the fungus that's the name of the fungus that's in the soil, and a bit about the epidemiology, and then I'm going to talk about 3 Canadian studies dealing with epidemiology in Northern Ontario that have been published and are out there. There's a lot of epidemiology on this in the United States and so forth, but I can confine it to Canadian data, mostly Northern Ontario. So case 1, I'm going to start off with some cases, and then I'll talk about the disease a bit more. So these are all patients that I've seen. Case 1, this was a 48-year-old male patient from the Sudbury area, and he was admitted to the hospital with, he was sick for about 2 months. He had this mid back pain, and about a 1-month history. He had this nodule on his buttock, this lesion on his skin that was coming out. And he was tired, fatigued, he was short of breath, he had a cough, but he wasn't producing anything, he wasn't coughing up anything, it was just dry. He had fevers and chills, and he lost about 12 pounds. So this is how this fellow presents to us in the hospital. I think he came in through the emergency room, I believe. So his occupation was, he was a phone company worker. He worked in the outdoors, he worked in a lot of wooded areas, and he worked in a lot of manholes and work in Northern Ontario, digging up manholes in his work. So his past history, he's got some coronary artery disease, he's had a couple of stents put in his heart, he's got a remote history of smoking, he has no history of tuberculosis or exposure to TB, and the reason why we ask this is because Blastomycosis, the way it presents, can be very similar to tuberculosis or be very similar to cancers, so it can be very difficult to tell when they present, what they've got. But he has no history of any cancers. His examination, he needed oxygen to breathe. His blood pressure was a bit low. He did not have a fever when I initially saw him. When I examined his chest, when I listened to his chest with a scope, it did not sound normal. He had what we call crepitations, which are abnormal sounds in the lungs. And he had this mid back pain, about in the thoracic area. And he had this lesion on his buttock. This is his lesion here of his skin. And of course, you can have lots of lesions that look similar to a lot of other things. You don't know if it's an infection or what it is, but he had this solitary lesion. And here's a normal chest x-ray. I threw this up so you can see what a normal chest x-ray looks like. I don't know if you've seen a chest x-ray before, but the heart is in the middle, the lungs are on both sides, you can see the ribs, and the lungs are pretty black. Okay, there's some markings in the lungs, and those are usually blood vessels, okay? The diaphragms are in the bottom there, and the spine down the middle, and the big thing in the middle is the heart. So that's a normal chest x-ray, and here's what his chest x-ray looked like. Okay, so compare it to the normal right there, and that's his chest x-ray. So obviously there's something happening in both lungs diffusely. It could be pneumonia, it could be cancer, it could be TB, you don't know at this point in time, okay? So obviously not normal. This is a CAT scan of his lungs. CAT scan is an x-ray taken this way, coronally through the chest, and those are the lungs on both sides, and they should be nice and black, but they're not. You can see all the white debris throughout both lungs. The thing in the very middle is the heart, the back is the spine, and but the lungs are not normal. This is a CAT scan going down into the liver and spleen. It's kind of hard to see. Here's the spleen here, and there are lesions here. You can see there's round black lesions here. It should be all a uniform tone, but there's lesions all in the spleen as well. I think he had a few in the liver that are harder to see. And then he had a scan of his back. It's probably an MR, and this is the thoracic spine here, all the vertebrae here. And you can see there's one vertebrae here is sort of destroyed, and there's something eating away at that particular vertebrae. So that was what's causing his middle of his back pain. So we did an aspiration of his back. They went in and did a biopsy or an aspiration with a needle, and this is tissue from the back. And all the light blue stuff is just inflammatory tissue, but you can see almost the black around spheres. That's blastomyces. So it lives as a yeast form in the body, and you get these very, very typical budding yeast cells. That's very typical on pathology. So the pathologist can pretty much look down and diagnose it even without culturing it because it's so distinct. So this was found right in the thoracic tissue from his back because it was easily accessible. And this was also the spine aspiration as well. You can see that there's inflammatory tissue. This is the light blue, and then the black, dark blue structures is blastomyces. So obviously you're not supposed to have that in that tissue, and that basically gives us our diagnosis. So this guy had basically what we call a disseminated pulmonary and extrapulmonary blastomycosis. So it was disseminated, it was widely spread in the body, involved not only the lungs, where you typically see it, but involved a lot of other tissues, including the buttock lesion on his butt. And we also biopsied that, and that had blastomyces in it as well. So he was quite sick. I'm not going to get into all the treatments and everything because it's irrelevant for you, but he was put on what we call ambisome, which is a very potent antifungal drug intravenously, quite toxic. But he needed that for 1 to 2 weeks, and then he went on a medication called itraconazole for about 12 months afterwards, for a whole year of therapy, and I believe did well. He was initially actually on a ventilator in the ICU when he was sick because he was so ill. So he did well, and he recovered and was on treatment for about a whole year to treat it. So that was case 1. Any questions about that?
Was his spine able to recover, or?
Mm-hmm. Usually just heals.
Yeah.
He had heals and scars. Now he wasn't left with any, there was no motor deficits. It wasn't affecting the spinal cord. It was affecting just the vertebrae. Had he left it longer, it could have affected the spinal cord, but it would usually just heal, scar. I don't know if he was left with any residual back pain. He might have had some residual back pain just as for mechanical reasons, yeah. No, most of the time we never do find that out. I'll talk a little bit about that, sort of where it's found, but that's part of the problem. It's very difficult to know. He had lots of different environmental exposures, and that's part of the problem, because you just don't know where. Case 2, this is a 70-year-old male patient from North Bay. He had a history of prostate cancer and malignant melanoma, which is a cancer of the skin from sun exposure. And he was referred actually by his oncologist, his cancer specialist, because he had this expanding isolated nodule on his left thigh for about 4 months. And otherwise completely asymptomatic. He had no symptoms, no fevers, no coughing, no shortness of breath, just this expanding nodule. And he had a biopsy of that because they were obviously concerned about cancer. He's got 2 different cancers going on here. He's got prostate cancer and he's got malignant melanoma. So is this thing on the thigh one of these that's occurring? But there was no recurrence of any cancer. So his past history, he has mining-related silicosis. So he was exposed to silica that would have affected his lungs somewhat, but he really didn't have much in terms of symptoms. He had high blood pressure. He didn't smoke. He had no history of tuberculosis, and he was just on 2 medications for that. And he had this expanding nodule on his thigh. The rest of his examination really was normal. I don't think I have a photo of it actually, unfortunately, in this case. But his chest x-ray was abnormal. Okay, he didn't have any symptoms, but he did have abnormality. If you look up there in the, on that side over there, the right side of the lung at the top, there's this round nodule up here. This is fairly normal, but up here there's something going on over here, and that's not normal. But he wasn't coughing. There wasn't anything there. This was a. Sorry, that was just a close-up of that area at the top of the right lung. So he does have abnormalities on his chest X-ray. So he had a skin biopsy of that thing on his thigh, and it showed these round, thick-walled, budding yeast cells, very typical of Blastomyces, and the culture, in fact, showed Blastomyces dermatitidis, which is the name of the fungal organism. So you have your diagnosis, and he was put on itraconazole for 6 months of therapy, and did well. So those are the two sort of typical kind of cases that I see. Some of them are kind of complicated. This is another case that I saw a few years ago, and this was presented as a poster actually in Liverpool in the UK by my medical student who actually wrote it up with me. And this was a case of Blastomyces in the lung that also affected the brain. So here we have, here's an MRI scan of the brain right here. That's what it normally looks like, other than that white thing right there. So there's your lesion. And when that happens, we don't know if that's cancer or is it an infection. You know, you can't tell from the MRI. You'd have to go in and do a biopsy of it or have surgery of it to determine. And he had that done. He had surgery of it, and it was Blastomyces. This fellow was a perfectly healthy 57-year-old male from Northern Ontario, worked as a construction worker in the north. I can't really remember what type of construction he was in, but he was out in the field doing construction. And he actually presented with what was called an expressive aphasia, so he had difficulty finding his words. And because of that, he had an MRI scan done. And lo and behold, he's got a lesion right in the area that affects your speech area, so he had difficulty finding words. So he had further investigations, a biopsy done. They thought it was cancer, but it wasn't, and it was Blastomyces. So it's not very common to find it in the brain. It only occurs in about 1% of cases, and I've only seen really 2 true central nervous system cases. This being one. That's why he presented it, because it was kind of unusual. And here's a case, not that I saw, obviously, but that's been 2 cases that were reported, and this was a publication of a Blastomyces acquired occupationally during prairie dog relocation in Colorado in 1998, and it made the literature because it was quite interesting. Blastomyces is not normally found in Colorado. I'll show you the distribution of Blastos. So it was unusual. So these 2 guys, there were a bunch of employees, and they were doing. I'm not sure what they were doing. They were out in Colorado. They were digging in old burrows for prairie dog relocation study. They weren't exposed to the prairie dogs themselves, but they were in the burrows and very close, in close contact with soil for prolonged periods of time. They thought that these 2 guys were in contact for about 5 hours digging out these burrows, and within about keeps clicking on and off. Is that normal? Is that your little connection?
I think our wire needs to be replaced, Nisma.
So they both developed disease within 13 and 18 days of being exposed, which is extremely short, because most people who get this disease, the incubation period is anywhere from 1 month to several months. So they think that these 2 guys were so heavily exposed to the inoculum in the soil. They breathed in so many spores that they got sick quite a way. They both got sick at the same time, when previously they were perfectly well. So they really thought that this was occupational exposure from their work that they were doing with prairie dog relocation. So there is an awful lot of publications out there on sort of true occupational Blastomyces, because it's very difficult to prove that it was occupationally acquired. Yeah.
Do you know how old the individuals are?
These 2 guys, I got the paper here. I can't remember. They weren't old. They were young men. I don't know the age of them. They weren't elderly or anything like that. I can pull it out. I can't remember the age. They were healthy. There was no problems with them. And just the fact that it happened both at the same time. And they think that it was found there because these prairie dogs had it in their system, and the burrows were high in nitrogen and organic content from feces, and also it rained a lot during that period of time, and it's the moist, humid conditions that lead to Blastomyces replicating in the soil. So probably the spore counts were quite high. So a little bit about the biology. There are various endemic mycoses around the world. Endemic means they're only found in certain geographic areas. Mycoses mean they're fungal infections. So there are certain fungal infections found only really in certain parts of the world. Blastomycosis is found in northern Ontario, Ohio, and the Mississippi River, and below the Great Lakes. I'll show you a map. There's histoplasmosis, which is found in the middle of the United States. Coccidioidomycosis is found only in southwestern USA, and there's various other ones as well that are found sort of only really in certain specific areas of the world. So blastomycosis is one of the endemic mycoses. It's also known as North American blastomycosis. It's caused by Blastomyces dermatitidis, which is the fungus. It's found in decaying organic material, and it has two different phases. It has a well, actually that's a dog that has it. It's found more commonly in dogs. The veterinary field is well aware of Blastomyces because dogs sniff on the ground all the time, so they see a lot of blasto. And in fact, when they start seeing a lot in dogs, that's kind of a clue that we might start seeing it in humans in that same vicinity. But this is the area where it's found in North America. It's probably exaggerated a little bit. It's found probably more. There's not much in Ontario, Southern Ontario, so I don't know why they have this covered in purple. It's because it's from the United States Journal, probably. But it's found principally in Northern Ontario here, over into Manitoba. It's not much in Saskatchewan and Alberta, so I don't know why that's there. And it's not found as much down here, but it's found below the Great Lakes and above the Great Lakes, not much in Southern Ontario, and just above the Great Lakes, this whole area, and particularly Kenora and Northwestern Ontario here. Okay. I recently went to San Diego a few weeks ago at a big infectious disease conference, big American conference, and there was a poster or two from American students on Blastomyces. He presented a case or two, and he had a little bit of the epidemiology of where it was found, and he had absolutely no idea that it was found in Canada at all. So I educated him. Anyways. So the annual incidence is about 0.62 cases per 100,000 people, mostly in Ontario, Quebec, Manitoba, and they say Saskatchewan, but probably mostly Ontario and Manitoba. So it has two phases. Fungus that's found out in the environment often changes its morphology. So in the environment, this is what it looks like. It's got these hyphae and it's got these small kinidiospores, very tiny, microscopic. It grows in the soil. You can't see it. You stir up the soil, you breathe it into your lungs. All right? You're not looking at a mold on the ground necessarily. You don't see it. So it's got this form, and then when you breathe in these spores, it goes into your lungs. It can sit there dormant. It may cause disease. It may not cause disease. Some people get disease. Some don't. And then at body temperature, the fungus turns into a yeast form, where you end up with these big, huge budding yeast cells. And it's those yeast cells that cause disease. It's not spread from person to person. You have to breathe in a conidial form from the soil. It's this form that can then spread from the lungs through the blood to other organs. And most commonly, we see it going to the skin and bone. And then less common to brain, about 1% of cases. So it starts in this conidia hyphal form, reaching the lungs, macrophages take it up, it forms a yeast form, and they end up with pneumonia, and it can spread through the blood, as I just said. Symptomatic disease occurs in about 50% of patients that are exposed, they believe, but I'm not quite too sure where they get this number from, because we don't know how many people are exposed, because there's no good test in any individual to know whether they've been exposed. There's no good blood test. There's no good skin test. There's nothing. In fact, many of you could have been exposed to Blastomyces over the years, and you just fall into the other 50% who never developed any clinical disease. But we don't know that because there's no good test for it, unless you actually get disease and then you get tissue to grow it. Most people develop lung disease, pulmonary disease. Some people develop very mild disease. Some people develop moderate disease, and some of them are extremely sick and land up in the hospital. And it can spread to all these other organs as well. So I think that probably one of the sentinel things about diagnosing it is patients most commonly present with a pneumonia that's just not getting better on regular antibiotics. This is the typical history I see often. They've been to different clinics, they've been to their family doctor, they have this thing in their lung, they're coughing, they're put on antibiotics, not getting any better, then it's something else, all right? And that's something else in Northern Ontario. One of the things is blastomyces. But you also have to be concerned about tuberculosis and cancers because it looks like that. It's very slowly progressive. It also presents on the skin. Here's some cases of blastomyces on the skin. For all of you that are not grossed out by photos. So here. This is a cancer of the nose. So you can see it looks very similar to blastomyces. And this is another condition called pyoderma gangrenosum, which is an autoimmune disease. It looks very similar to these lesions as well. So you can't really tell by the skin lesion that it's blasto until you biopsy it. So these are some of the cases that I saw in 2014, 2015, for instance. I'm not going to go through all these, but these are other cases, ranging from 20-year-olds to 68-year-olds in various, some Manitoba, Sudbury, Killarney, Manitoulin Island, Birch Island, Garson, and they all presented with various types of pneumonias and various types of complications. And these are the cases I pulled up for a presentation I did before. And these are the ones I had seen between 2014 and 2015. So I see maybe 1, 5, 6, 7, 8, 9, 10 cases a year of blasto. And I don't see them all. Many of them are treated and seen by other physicians and in Killarney, Manitoulin Island, by family docs, and some go missed. So in terms of the epidemiology, there are 3 studies I'll go through briefly. One is looking at the epidemiology of the disease in Manitoba hospitals. One is in Ontario from 1994 to 2003, and the last one is in Northwestern Ontario from 2004 to 2014, which was actually primarily authored by the medical student I worked with. He's out in Calgary now. So in Manitoba, this was an old article from 2002. They looked at 143 cases of blasto, and a lot of the Manitoba cases came from Kenora, because Northwestern Ontario refers to Winnipeg for a lot of their complicated diseases, or they refer back to Thunder Bay. But Kenora's, I think, is actually closer to Winnipeg than it is to Thunder Bay, so a lot of referrals go that way.
We know that.
Yeah, you know that, eh? Yeah. So they looked at 143 cases. Actually, of these, 23 patients traveled to Northwestern Ontario. No, sorry, I think there were 23 patients from Manitoba. I don't know, never mind. I messed all up. I don't know.
Is that where they would have been exposed? Would be
they were exposed.
Ontario?
Yeah, I think so. Yeah, they were exposed in Northwestern Ontario. They don't necessarily live in Manitoba. Here's a map in that study showing the annual incidence per 100,000 population. And normally the annual incidence is about 0.6, so like almost 1 case per 100,000. But in the Kenora area, it can go up to about 7. And Kenora and this whole area is probably the highest incidence of blastomyces in the world. Okay, so it's very hyper endemic in that area. That's probably why you're being asked questions when you go and do your CROSH work up there. Okay. Mean age was about 38 years in this study. Mostly male. It is found more commonly in males. In all the studies, it's about 60 to 70% males. They occur in all decades of life. Most of them developed a lung disease. Some of them developed skin disease, some bone, a central nervous system disease at about 1.4%. Asymptomatic cases, these are probably patients that have no symptoms, but were found to have something incidentally that was biopsied, but they didn't actually present with any symptoms. I don't know for sure. I'd have to look at the study more carefully. The duration of symptoms, patients were usually sick for about 2 months before they presented. So, you know, a large variation in terms of time when you present. So that can be part of the educational piece to people out there. I'll talk a bit more about that in a second. So the second epidemiologic study was one in Ontario, 1994 to 2003. And here they looked at the incidence in various parts of Ontario, including southern Ontario. In the north, there were about 188 cases. The rate was 2.44. But you see the rest of Ontario here, the rate 0.11, 0.08, 0.02, 0.04. I mean, there's a smattering occasionally of cases in southern Ontario, but really it starts in northern Ontario. Diagnosis by year, there seemed to be an increase in diagnoses from the 1990s. Number of cases going up to about 70, 2002, 2003 in this study. By season, you can see cases all through the year, but we see it's been in the reports, you know, most of the epidemiological reports, there are more cases presenting in the winter than in the summer. And that's what I also see clinically in my practice. I see more of them in the winter, but there's no blastomyces in the winter. Everything's covered in snow. You're not going to be exposed to it in the soil. Everything's covered up. And the reason is because they get exposed in the summer and the fall. And because the incubation period is 1 to several months, they don't present to medical care until in the winter. So I commonly see cases in the winter that were acquired in the summer or the fall, and then it sits there and brews, and then they finally get sick enough that they come to presentation. All ages, it seems to peak in this study, you know, 40 to 50 age range. So that's that study. And then this study here was written by the medical student I worked with, Dan, and he's right now a first-year resident. He graduated from NOSM last year from Thunder Bay campus, and he published the first authored paper here of blastomyces in northwestern Ontario. So he basically did a 10-year review of cases, I think that were at the Thunder Bay Hospital or in that area. He looked at 64 patients over 10 years. Kenora had the highest incidence worldwide, higher rate in Aboriginals, and higher rates in males. More diagnoses in winter months, for the reasons I just explained. The case fatality rate was about 20% in this study, so about 13 of those 64 patients died. So this is not a benign problem, okay? That's pretty high, 20% fatality rate. That's a lot of deaths in just 64 patients. In this study as well, he looked at the total number of patients and the various ages. So most of them, the total number of patients in this particular study were younger, actually 20 to 29. You know, between 20 and 30, rather than the previous peak we saw in the 50s and 60s age range in the previous study. So in terms of, I'm not going to go a lot into treatment, because that's not going to be important to you, but there's various drugs we can give intravenously or orally to treat this. And the treatment has to be given for a long period of time, usually 6 months to a year, depending on how extensive the disease is. I'm not going to get into that. Itraconazole, which is the main drug we use to treat it, overall, in some studies in the past, the cure rate was around 90% if you got on treatment early enough. I'm not going to go into this. To you, the Sudbury District Health Unit has put out notices to the public and to the people at large regarding blastomyces. That blastomyces is not a reportable disease not a mandatory reportable disease in Ontario. As of about 1989 or 1990, they took it off. It is a reportable disease in Manitoba, but only for surveillance purposes. Public health doesn't go after patients. So in other words, if you have blastomyces, the public health is going to be calling you up and asking you where you got it, because it's useless information for them, okay? This is not a disease that's spread person to person. So public health is not as concerned about it, like tuberculosis, where they got to track you down, make sure it's not spread to your family members. This is not. So it's come off the reportable diseases in Ontario. But they have put out various notices about blastomyces, warning about farmers, forestry workers, hunters, cottagers, people who spend a lot of time in the outdoors, excavating, digging under buildings, or gardening. I mean, I see blastomyces in patients. I've seen women who they don't spend any time sort of outdoors. They have no cottage. They're not digging around anywhere. They might do a little bit of gardening in their garden in town, and they get blastomyces. Probably because they just happen to be exposed to the soil that just had blastomyces in it. And there's no real way of knowing that because there's no good testing you can do of soil. The testing is very unreliable. It's very hard to grow at that stage, at the mycelial stage, or the cnidia stage. The yeast form stage is easy to grow, but that's when it's in a person, when you're infected. How can you avoid it? Well, they just say, what do they say? They say avoid activities that require working with soil. Well, how are you gonna do that, right? Masks. I mean, you can wear, dress properly. Put it that way. Wear masks, I suppose. But there is no evidence in the literature anywhere that proves that wearing a mask will reduce your chances of getting blastomycosis. Though theoretically, it probably would work if you were very closely exposed to an area where there's a lot of dust, you're digging up a lot of debris in an occupation. You would think theoretically it would work, but there's nothing to prove definitively that it does. And it's very hard to know where you're actually exposed. You can't wear masks all the time. I think the biggest thing that can be done is education about where it's found geographically, what your risks are in terms of exposure. You spend a lot of time in the outdoors, and how it presents. So then you can be aware of that. So really your take-home messages, my last slide here, it can be difficult to diagnose because of the way it presents. In Northern Ontario, I think really people just have to be aware of kind of this non-resolving pneumonia, not getting better on antibiotics, and you're exposed to the outdoors a lot, even if it occurs in the winter months, when you think you may not be exposed, all right? That's sort of the key. And don't expect your physician necessarily to know that, unfortunately. You would think. But that's why they go on multiple antibiotics, because they go from place to place to place, and nobody really makes the diagnosis. Okay, until something gets worse and worse and worse, and something happens with the patient. I think a lot of physicians are aware of it, but not all the walk-in clinics and primary care physicians are aware necessarily. Okay, so I think educating people in the public and working in the outdoors a lot of this might be useful. It can be suspected as a cancer or tuberculosis. Skin nodules can develop, as you've seen, and treatment is with these various